Excellent. Okay, let's do it. So first of all, I would like to finish up hematology. So we have just like a couple of pages left. And after that, we are going to start, I think, genetics, but you still have the window to vote. So, anti-cancer small molecular inhibitors. So there is again some medication that work at some specific pathway that are associated with some diseases. When we speak about pulmonology, I'm going to discuss a few cancers in the lung. There is like small cell carcinoma of the lung, there is squamous cell carcinoma of the lung, there is the adenocarcinoma of the lung, and each of them has a story. I just want you to notice something here. There is this, the basically the lectinib and these tinib, but don't make that confuse you because there's other tinibs that work for something else. But the ALK, which is a kinase actually, the tinib can inhibit it. So what is ALK? An ALK is a tumor oncogene. And this tumor oncogene, if it is inhibited, that's it. Well, it comes from a tumor oncogene. It's basically a tyrosine kinase. And it can be inhibited by this guy. So if it's inhibited, there will be no proliferation, and that can help to treat non-small cell lung cancer. Okay, so edema, rash, diarrhea are side effects. The other tinib here we have, they work at the EGFR, also for non-small cell lung cancer. Well, these are not so high yield, but this one is. Imatinib and dasatinib and nilotinib, especially imatinib, is high yield. Why? Because it's a tyrosine kinase inhibitor. Remember, the tyrosine kinase was created by the help of the BCR-ABL translocation. The BCR-ABL was created because of formation of a Philadelphia chromosome, which was due to the 922 translocation. So we can utilize the imatinib to decrease the tyrosine kinase activity, which basically leads to their proliferation, and it can be used against the CML, ALL, and GI stromal tissue tumors. So it can lead to myelosuppression and more LFTs and edema and myalgia. Ruxolitinib, it's basically work at the JAK-STAT pathway, and we spoke about it before. It inhibits the JAK, so no JAK means no STAT. No STAT means basically no proliferation of the RBCs, which can be utilized to treat polycythemia vera. The next drug is the zumib. So they are a protease inhibitor, and they can lead to a cell cycle arrest at the G2 and to the M phase, which basically can lead to apoptosis. Remember the proteasome, the ubiquitin proteasome pathway were responsible for clearing out any abnormal proteins. It was one of the parts of the proofreading in the cell cycle, which is the G2. So we can use it to treat multiple myeloma, mantle cell lymphoma. Mantle cell lymphoma, please do not forget, it was an 11-14 translocation, and it's quite aggressive. Peripheral neuropathy can occur in this drug, also herpes zoster reactivation, because the immune system will be inhibited. So here we have the RAFs, rifampicin. So they work at the BRAF and can be used in melanoma. I know that I told you that you should not know the names of like for which disease we are using it for, but from this page I can tell you that first, imatinib and CML, you have to know that. Polycythemia vera and ruxolitinib, you have to know that. And this vemurafenib, they always ask it, and melanoma, you have to know that. So we also give it with a MEK inhibitor, which we are going to speak about on like the musculoskeletal chapter, which contains dermatology. And that drug is going to be tramatinib, which both of them help to treat melanoma. Guys, what do you think is the most important prognostic factors of a melanoma? If I give you like two melanomas, melanoma A and melanoma B. Melanoma A is on the skin, and the width of it is, let's say, 14 centimeter, and the depth of it is 1 centimeter. Melanoma B is 1 centimeter in size, but 4 centimeter in depth. Which one is more dangerous? It's melanoma B. The most important prognostic factor for melanoma is the depth of the invasion. Okay? Okay. So the next thing is called palbociclib. It's a cyclin-dependent kinase arrestor. So that is going to inhibit the G1 to the S phase transition, and it can be utilized in breast cancer, also can lead to myelosuppression and pneumonitis. And olaparib, it is a body ADP ribose polymerase inhibitor, decreased DNA repair, also low yield. It can lead to myelosuppression, edema, and diarrhea. So the high yield from this one is the melanoma, BRAF, and this drug. I really cannot pronounce it. I have a problem saying it. And this one, the JAK-STAT inhibition with polycythemia vera and the ruxolitinib, imatinib, and the CML, and how it inhibits the tyrosine kinase made by the BCR-ABL. And that's it. These are the high-yield ones. So let's speak how can we reduce the horrible side effects of some medication. For example, we have something called emifocytine. Remember, we spoke about them when we spoke about the platinum drugs. We said that ME can decreases the nephrotoxicity by reduction of the free radical injury. The dexamethasone, it decreases the risk of having cardiotoxicity, a dilated cardiomyopathy caused by the anthracyclines, like doxorubicin, for example. Why? Because it's an iron chelator, which prevent the Fenton reaction from occurring, which is the thing that is leading actually to the dilated cardiomyopathy. And the next one, leucovorin, also known as folinic acid. So this folinic acid is going to prevent us from getting what? Getting myelosuppression from methotrexate. So it's a rescue, right? Also enhances the effect of 5-fluorouracil because basically it activates the thymidine synthetase because it increases the pathway here. If you go to page number 3, you will understand what I'm speaking about. Mesna can be used for hemorrhagic cystitis, yes, which is caused by cyclophosphamide and efosfamide. So sulfonyl hydryl component that bind to acrolein, which is the toxic metabolite of cyclophosphamide and efosfamide. You might think this is low yield. It's not. Mesna is always a question in the USMLE. Acrolein is starting to become a question in the USMLE. They do ask which substance is the toxic substance in cyclophosphamide. The answer is Mesna. Okay, also Mesna can prevent the cancer. Why? Because hemorrhagic cystitis can progress and actually become cancer. Resiburicase can be used in tumor lysis syndrome because it helped to convert the uric acid into allantoin, and that is going to be secreted in the urine. Ondansetron and the gransitron and the metoclopramide and the prochlorperazine. The first one is a serotonin inhibitor, and the second one is a D2 inhibitor. They can be used for acute nausea and vomiting, usually within 1 to 2 hours after chemotherapy. Now I have a question. If you get a question and they ask you in it, oh, patient on chemotherapy, he vomits a lot. Which of the following medication would you like to prescribe for him? And they give you ondansetron and they give you metoclopramide. Which one will you choose? And let me be even little bit more of an asshole. So I'm going to also give you abribitate. So which one of these will you choose? If you choose metronidazole, you will be wrong. If you choose abribitate, you will be wrong. The correct answer that if the patient is acutely getting the chemotherapy, that you must give the ondansetron. Let me explain why actually, because if you understand why, it becomes easier to memorize. So guys, the chemotherapy mainly destroys which type of cell? Which type of cell is most commonly to be destroyed? Okay, let me just click this. Okay, so basically rapidly dividing cells are the most likely cells to be destroyed. Okay, so if we speak about the rapidly dividing cells, we speak about which type of cells? We speak about like crypts of the intestine. We speak about the stem cells. We speak, yes, this one, absolutely, I totally agree, you are right. So these type of cells are the most likely to be destroyed. Okay, now a tricky question. Where is serotonin produced in our body? Excellent. It's in the intestine. A lot of people think in the brain. You are right. I'm not saying you are wrong. It's in the raphe of the brain. But most of the serotonin, most of it, is actually produced in the intestine, not in the brain. Okay, good. So the next thing we have here is as follow. If I give chemotherapy, the intestinal cells, as I said before, what will happen to them? They will destroy. When they destroy, what they are going to release? What are they going to release? A lot of serotonin. And serotonin is going to lead to what when it's really high? Well, not exactly serotonin syndrome, but serotonin will be high. It will go to the area postrema of the brain. Area postrema of the brain is the center of vomiting inside of our body. So the area postrema of the brain is a receptor for sensing serotonin, which will induce vomiting. Okay, where is area postrema located? The answer is located inside of the fourth ventricle of the brain. Speak about it more in neurology, actually. Okay, so abribitant, it's an NK receptor antagonist. Also, it can be used in the late nausea and vomiting more than 24 hours after chemotherapy. But acutely, you would like to use ondansetron. Okay, the next one we have is the recombinant GCSF. When you see GCSF, it means it's a granulocyte, right? But it's GM, it's a granulocyte and monocyte. Let's take a look. So this guy, the first one, vilgromycin, it has a G, right? So it works on the granulocyte. The next guy, it has a G and it has an M. So it works at granulocyte and also at monocyte, okay? So they can be used for the neutropenia. And finally, the apotin alpha recombinant erythropoietin, which can be utilized in anemia. Who like to abuse this? Who takes the apotin from the cancer patient and takes it for himself? Athletes, absolutely. Okay, so let's speak about key chemotoxicity. See this guy, the chemotoxicity guy? You will always get a question about it, mostly this question. But in general, you will get a question about it. Let's start like this. So we have the cisplatin and carboplatin, cisplatin and carboplatin, the platinum drugs. They lead to ototoxicity. And remember, we always said any drug that leads to ototoxicity also lead to we saw this in aminoglycoside, for example. No, not neurotoxicity. I told you before, any drug that leads to ototoxicity lead also to nephrotoxicity. Nephrotoxicity. We saw it in aminoglycoside before. Remember, oto and nephrotoxicity. So any medication that leads to ototoxicity does also lead to nephrotoxicity. So you can see here another example. Don't forget about aminoglycoside. They always ask about that. It also leads to auto and nephrotoxicity. So cisplatinum and carboplatinum can also lead to nephrotoxicity. Vincristine. Remember the lady, Christine, who was paralyzed, like on a wheelchair? She had a peripheral neuropathy. Yeah? So you can see how the limbs, all of them are affected. Bleomycin and bisulfan, I kept annoying you about them because they lead to pulmonary fibrosis. Oh, who's going to be the king that will know which third drug I told you about also led to pulmonary fibrosis? The third drug was, oh, nice, methotrexate, right? Methotrexate. Okay, good. Doxorubicin and daunorubicin can lead to cardiotoxicity. So which test you should do regularly? Is it a echocardiography, or is it an ECG, or is it what exactly? Which test should you do exactly? For checking for cardiotoxicity? For checking for cardiotoxicity goes by the anthracycline, which are doxorubicin and daunorubicin. Which test should you do? Is it an echocardiography? Is it an ECG? Or is it an Holter? The answer is correct. It's echocardiography, by checking the ejection fraction. So basically, it's a way to ask you, how do we check the ejection fraction? The answer is echocardiography. Remember, we trust her because she has breast cancer. So that trastuzumab works at the HER2/neu, and that can lead also to cardiotoxicity. You trust her, but she broke your heart. Okay? So trust and cardiotoxicity. Don't trust her because she's going to break your heart. The same thing, you need to check the ejection fraction with an echo regularly in these patients. Okay, guys, all of these are super important, but the most important one is actually this one. Cyclophosphamide leading to hemorrhagic cystitis and even cancer. Keep in mind that you can prevent this with Mesna, which binds to the acrolein, which is the toxic substance in the cyclophosphamide. So non-specific comment, interstitial, sorry, I will tell you, just a second, I will not make the mistake. Urothelial bladder cancer. Urothelial bladder cancer. Okay. Do you remember what led to squamous cell carcinoma of the bladder? Squamous cell. Actually, tobacco can lead to both urothelial cell, which is like, transitional cell carcinoma. No. It was a protozoa, guys. It was a protozoa. Which one? Like a helmet, basically. Worm. So that was Schistosoma hematobium. Okay, Schistosoma hematobium can lead to bladder cancer. Schistosoma mansoni can lead to liver fibrosis and portal hypertension. Schistosoma mansoni has a lateral spine. Schistosoma hematobium has a terminal spine. So terminal spine, hematobium. Lateral spine, mansoni. Non-specific common toxicity of nearly all cytotoxic chemotherapies include the following. So all of them destroy the rapidly dividing cells. So for example, the hematopoietic stem cells, which lead to myelosuppression, neutropenia, anemia, thrombocytopenia. GI toxicity, which lead to nausea, vomiting, and the mucositis, which is an inflammation of the mucosa of the oral cavity, for example. Why? Because the cells there are not replacing. They will lead to destruction of the hair follicles, which lead to alopecia. That's why we ask our patient with cancer to shave their hair, because it's going to fall down. And when they see their hair falling down slowly, and for example, they try to put their hand on their hair and they see all of the hair fell into their hand, that is going to lead to psychological problem in the patient. They become really scared, So that's why we advise them to shave it before it falls. One more thing. If you see such symptoms in the patient, I mean like the alopecia, the GI toxicity, and the myelosuppression, is it something bad or good? What do you think? Is it something bad or good to see the symptoms? Alopecia, GI toxicity, diarrhea, anemia, all of this stuff. It's actually a really good thing to see that. Why? Because the drug is working. Absolutely correct. That means that the medication is actually working. The medication is working, the cancer is getting killed. If the rapidly dividing cells, such as the hair follicle, are getting killed, that means that the cells who are more rapidly dividing than the hair follicle, which are the cancer cells, are also getting killed. Okay, guys. So that's it for hematology. Oncology, we are done with it. Let me just take a quick look what you have decided finally. So whatever you have decided, we will stick with it now. You cannot change right now. So that is going to be genetics. I'm going to start with you genetics, and after we finish genetics, we are going to touch up on MSK. I'm going to like now we'll have a 10 minutes break. I'm going just to after today class, I'm going to write you the schedule for the rest of the month basically because this month is small. I hope that until the end of this month we'll finish the MSK and we'll finish the genetics. It's highly possible. MSK is not that long. And when we finish both of these, just a quick reminder, did we speak about vasculitis? Did we speak about vasculitis? Yeah, we spoke about it here. They explain it again. Anyway, so yeah, we'll finish MSK quite quick. Exactly, it was in cardiology, but they now moved it to MSK. So okay, so after MSK, we have neurology, psychiatry. Neurology is a bit long, so that will take like a couple of weeks, but psychiatry is super small. It will take like a couple of days. Reproductive will take like a week, while respiratory will take 3 days. That's what cool about what system we have left. Like yeah, neurology can be a little bit difficult, but other how like we are in a fine situation. So still, I highly think that we can finish until the end of March. If not, maybe 1 or 2 more weeks, but we will see. Hopefully, we'll finish until the end of March. So see you guys in 10 minutes. Hello, everybody. Welcome back. So let's take a look. We are going to start with genetics. Ooh, difficult topic, I know. And the problem, there's only actually one problem about this topic that I have to be like truthful with you guys from the beginning. This topic is poorly explained in first aid, so I want you to be a little bit more focused than other topics. I will be telling what you need here, but still, few things I really cannot help you with. You will go to your word, you will do the question, you will get it wrong, and you will learn from it. It's sadly not written perfectly in first aid. So let's take a look. Can you see my screen, by the way? Okay, good. So general terms that we need to learn about. The first one is codominance. If you remember when we spoke about the blood groups, I told you that both father allele and both mother allele contributes to the baby gene, right? So baby gets one gene from daddy, one gene from mommy. That's what codominance means. It means that the offspring, which is the baby, general terms. Offspring means like children, like boys and girls. Parents, you know who's parents. A chromosome is this guy. We have 46 chromosomes. 2 of them are sex chromosome and the rest are somatic chromosomes. Each chromosome we have a chromosome 1, it's identical to another chromosome 1. So in reality, we have a 22 duplicate of chromosomes, okay? And we have the 6 chromosomes left. Okay, so we have codominance in which both parents contribute to the phenotype of the baby. We saw it in the blood groups, if you remember. We will see it again in pulmonology when we speak about the alpha-1 antitrypsin deficiency. But the difference in that disease, it will be divided in Z and W. Z is the sick allele and W is the healthy allele. If you forgot, just make it like I do it. Sick, right? It's sick. So Z is the sick allele and W is the healthy allele. Also the HLA groups. So all of these diseases and like things, both parents contribute to the genotype of the offspring. Okay, so the next thing is something known variable expressivity. You must be able to compare between it and the pleiotropy. So what is it? Variable expressivity, let's take a look. I have this example that I always like tell to everybody. Just a second. Okay, let's say that we have here a genotype, right? And here we have phenotype 1, phenotype. So again, here is genotype. Here, phenotype 1, 2, 3. Let's speak about a disease. Neurofibromatosis. So, neurofibromatosis can be encoded by the same gene, but in some patient, the first phenotype or the presentation is going to be cafe-au-lait spots. If you don't know what that is, I will show it to you. Yeah, something like this, cafe-au-lait spots. Okay, so is it severe or mild if the patient has only cafe-au-lait spots? What do you think? Is it severe or mild? Super mild. Okay, the patient then has neurofibromas, right? Let's say the new patient we have has 1 plus 2. I mean, he has the cafe-au-lait spots, but now he has the neurofibromas. Okay, so he's moderate. The third patient has tumors, brain tumors, for example. That's the severe case, right? So variable expressivity means that the same genotype can encode to the exact same disease, but in different severity. So for example, patient 1, B1, he will have only phenotype 1. Patient 2 will have phenotype 1 plus 2 plus 3, right? Because he's more severe. So variable expressivity means that the same gene can encode for different severity of the same disease. Okay, so variable expressivity is all about the severity. Patients with the same genotype have varying phenotypes. Two patients with neurofibromatosis may have varying disease severity. You are like, come on, Iyad, you are obsessing so much about this, like the severity thing. Why? Because it's the only thing that helps us to differentiate between variable expressivity and pleiotropy. In pleiotropy, one gene contributes to a multiple phenotypic effect. You are like, wait a second, that's exactly what you told me in case of variable expressivity. You said that one gene can have variable phenotype. Yes, I said that. So what is the difference? In the first disease, we took neurofibromatosis as like an example. Now we are going to speak about phenylketonuria. In phenylketonuria, the idea is like this. Let me just do it here. Phenylketonuria. The patient can have Mustéa d'Or. He can have albinism. He can have intellectual disability. Are these things related to each other? The answer is no, they are not, right? It's totally not related to each other. It's totally different thing. You're like, okay, so patient 1, what he will have? Well, patient 1 might have 3 plus 1, right? Patient 2 might have 1 alone. Patient 3 might have 2 plus 3. So as you can see, different patients have different phenotype, but it's not according to the severity, because there is no actual meaning of severity here. It's Mustéa d'Or, albinism, or intellectual disability. There is no progressive scale of severity in this disease. Thus, if there is no progressive scale of severity in a disease, it cannot go variable. We cannot say that, oh, this disease has variable expression. No, he has pleiotropy. Untreated phenylketonuria manifests with a light skin, intellectual disability, and the Mustéa d'Or. Anticipation mean that an increased severity, incomplete penetrance. Okay, so that's variable expressivity versus pleiotropy, now incomplete penetrance. So the question is like this. We have a patient who is having Marfan syndrome. By the way, guys, you need to learn how to do pedigree. So I'm going just to do a pedigree with you guys here, a small one. So what does the circle mean in a pedigree? A circle. Woman, a square is a man. Connection between them means they are married, right? Okay. So this lady is sick. This woman, all of them are healthy, but this woman got married to some guy and they got a baby that is sick, okay, with Marfan syndrome. What is the mode of inheritance of Marfan syndrome, like inheritance? I hope you did the video of Dirty Medicine that says Von, ALS, RBMEN, Tubesens, Pearson, Huntington, Ehlers, Marfan, Dan. Marfan is autosomal dominant, okay? If you don't know what I'm speaking about, there's a Dirty USMLE autosomal dominant. Yes, this sounds clutch. Autosomal dominant. Okay, so there is this song, and there is one for the
So an example of the question that you might see.
Basically, they have little songs that help you to memorize the whole thing. I mean, all of the diseases required from you to memorize. So, for example, here he has the song Von, ALS, RBMEN, Tubesens, Pearson, Huntington, Marfan, Ehlers-Danlos, NF, 1 and 2, don't fab too much, autosomal dominant. Yes, this song is clutch. Okay, so you can see how you can basically know all of the diseases that are autosomal dominant from here, like Marfan syndrome. Anyway, let's go back to our pedigree. So the pedigree here, notice something. Is mommy of, so we have, they sometimes put numbers here, like number 1, number 2, and number 3. That means first generation, second generation, and third generation. So the mom in the second generation, is she sick? Is she sick? You are correct. She is not sick, but how the hell the child got sick? It's an autosomal dominant disease. That means she actually got the disease gene. But how she did not develop symptoms? It's autosomal dominant. Yes, it's 50% chance, I totally agree, but since her child has it, that means she does have it as well. So how she has it, but she has exerting zero symptoms? The answer is incomplete penetrance. So it's individual who have the mutant genotype but do not show a mutant phenotype. Okay? Yes, absolutely. So there is like 50% chance the baby is going to be healthy or affected. Basically, if I take this, it's looking like this. So the small a is the diseased chromosome, right? First of all, you have to divide it into gametes. So this is the husband, this is the lady. And the lady, you can take the two gametes, which is the big A and the small a. But here, because there is two big A's, you only can get one gamete, right? And then you need to distribute them like this. So it's either going to be big A, or big A, small a. Yeah, so 50% chance of being sick or healthy. So they write here incomplete penetrance. Not all individual with a mutant genotype show the mutant phenotype. The percentage of penetrance multiplied by the probability of inheriting genotype is equal to the risk of expressing the phenotype. So for example, if we say about a disease like familial adenomatous polyposis, does anybody remember what is the penetrance chance in it? Don't say 50%, I will be sad. 50% is the chance of giving it to, no, familial adenomatous polyposis is autosomal dominant disease. But the chance of transmitting it is 50%, yes. But I'm saying if the patient actually has the mutation, what is the chance he's going to develop symptoms and cancer? The answer is 100%. You are right. It's 100%. That's why we do a procedure called like a prophylactic. Prophylactic, what do we do on this patient? We remove his colon, right? Prophylactically. Okay. So let's take a look. The next thing we have here, yes. So the penetrance of that disease is 100%. Let's say that the chance of inheriting that disease, if only one parent is affected, is 50%. So they write how to calculate the risk of expressing the phenotype. The probability of inheriting the genotype, which is 50%, multiplied by the penetrance, which is 100%. In this case, it's going to be 50% still. But you need to be careful because penetrance is different from different diseases. But on the exam, they will tell you which disease are you dealing with and which penetrance it has. Okay, so BRCA. Anybody know Angelina Jolie? She had a BRCA positive mutation. What she did? She had a surgery. She removed, she had a mastectomy, removed her breast. Yes, because of BRCA mutation. Well, guys, she has the mutation. Does it really mean that she always going to develop the cancer? Is it 100%? Yeah, that's true. This is why we, as physicians, don't check. We do not check all ladies for BRCA mutation, except those of high risk, okay? We only check those with high risk for BRCA mutation. Other how we do not check. Why? Because the last thing you want to do is overdiagnosing BRCA mutation, making so many ladies do mastectomy, overloading the medical system, which is going to paralyze it, okay? The medical system is not as strong as you think. If you put so much on it, it's going to break. So in the step 2, you will learn that we do not do the BRCA gene checking for everybody. So BRCA gene mutation do not always result in a breast or ovarian cancer. Okay, so pleiotropy, we spoke about it. Anticipation. Anticipation means with each generation, the disease is going to become much worse than the previous generation. So increased severity or earlier onset of the disease in the succeeding generation. So but this is only in the disease that have a trinucleotide repeat. For example, like Friedreich ataxia, Huntington disease, myotonic dystrophy, stuff like that. Only those who have a trinucleotide repeat. You are like, what is this? Well, don't worry about it too much. I'm going to teach you what I'm speaking about. These basically are these diseases. So let's get back here. Trinucleotide repeat disease include Huntington disease. So if the patient got Huntington disease at age 40, his son is going to get it at 30 with more severe symptoms. But his grandson is going to get it at age 20 with more severe symptoms. So that's anticipation. With each generation, there is more severe symptoms and earlier representation. Yeah, well, you might think about it logically like that. I mean, you cannot tell your patient don't have kids, but logically tell him, look, this is the situation. If you want to have kids, it will be on you. You decide. You know, you cannot like tell the patient what to do. So, but yeah, you need to let him know that this anticipation exists and that the future generation is going to have it much worse than he has it and much more earlier, okay? So why this happen? Because each generation is going to have more trinucleotide repeat expansion than the previous generation. Okay, so loss of heterozygosity. So what is this? If you remember when we spoke about tumor suppressor gene, I told you that we need to lose how many alleles? Was it 1 or 2? Tumor suppressor. Yes, it was 2. So for the tumor suppressor gene, you had to lose 2. If you are born, yes, if it is oncogene, you only need 1 mutation. You don't need 2 if it's an oncogene. But tumor suppressor gene, you need both of them from both alleles. So let's take a look here. So loss of heterozygosity, it's like, let's say that I am born and I already have a mutant 1 tumor suppressor gene. So I already have one of them knocked out, right? So I'm already having, I'm heterozygote for the cancer, but I don't have it. Why? Because my other allele is compensating for it, right? So if a patient inherits or develops a mutation in a tumor suppressor gene, the wild type allele must be deleted, remuted before cancer develops. This is not a true of oncogenes. Oncogenes just need one of them. So the loss of heterozygosity, for example, you are born with one mutant gene, right? That means you are at risk. Let's say that you smoke, you do something like that, and you have a mutation of the other tumor suppressor gene. Now you get the cancer. That's loss of heterozygosity. Retinoblastoma and the two-hit hypothesis, that's, yeah. So basically, retinoblastoma is caused by an RB tumor suppressor gene mutation. So that requires both of the mutation. Also Lynch syndrome, which is like basically the hereditary non-polyposis colorectal cancer, and Liefers-Mallis syndrome, which has the cerebellum mnemonic, if you remember. So let's see. The next one is dominant negative mutation, which means something like this. They write, it exerts a dominant effect. A heterozygote produces a non-functional altered protein that also prevents the normal gene product from functioning. You're like, wait, what? So basically, I like the examples they give. So if we speak about tumor suppressor gene, the B53, right? If the B53 is not like working normally, they write a single mutant P53 tumor suppressor gene result in a protein that is able to bind the DNA and block the non-mutant, the normal one, the B53, from binding to the promoter. You're like, wait a second. So are we saying that basically there is one tumor suppressor gene that if we only lose one gene of them, one allele, we still can have the cancer? The answer is yes. It's the B53. Why? Because it has this dominant negative mutation, okay? So again, the only type of tumor suppressor gene that requires one mutation for the sake of causing the cancer is the B53. Why? Because it has dominant negative mutation. So if one allele is messed up, he's going to mess up the other allele. Linkage disequilibrium. We know that we have 22 somatic chromosome duplicate, which means 44. So 22 for now. Let's think, if we take one of them and we take a look at it, so it has it has this structure. Let's say, I'm not sure, I'm just saying an example. Let's say that disease 1 is here, like diabetes mellitus, and the disease 2 is here, like hypertension, right? You can see that the diabetes mellitus and the hypertension are in close proximity to each other, right? So diseases that have close proximity to each other on a certain allele, they have much more likely of occurring together in the real population. I'm not saying in the same human being, but in a population. I mean, if in the whole population, these two genes are located near each other, there is a high chance that if one of them is going to be messed up, the other one is going to be messed up as well. Tendency of certain alleles at two linked loci to occur together more or less often than expected by chance. So it becomes more likely because they are located like close to each other. It's measured in population, not in a family, and often varies with different population. So yeah, it's not something you will tell your patient about. It's something for the meta-analysis people, you know? So the next thing is mosaicism. The idea of this one is actually interesting. I have a question, guys. Can a patient with Down syndrome have children? Well, normally he cannot. Normally he is unable to have children. He's unable. Except in one case, which is mosaicism. Mosaicism only happens in 1% of the population. So you're like, why the hell are you opening your Facebook page? I'm not trying to share it with you guys. I'm just trying to show you a case of Down syndrome child. So just a moment. Basically, basically this guy, that's the son of this guy with Down syndrome. So how come there's this guy from this guy? This guy should not have children. Well, yeah, but he has mosaicism. Mosaicism basically is a one way that Down syndrome can occur, and it's the only case where a Down syndrome patient can actually have children. Okay, so let's take a look at it. Mosaicism present of genetically distinct cell lineage in the same individual. Okay, so you are like, wait a second. If you take from me two different cells, one from my skin on the right side and one from my skin on the left side, they are going to have a slightly different DNAs? The answer is yes. So somatic mosaicism and gonadal mosaicism, what is the difference between them? The somatic one, the errors and the problems is going to be only in this person, not in his children, which is the case in our friend here. Gonadal mosaicism, it means that our person here who is living right now most likely will be asymptomatic, and the symptoms are going to be only in the baby, in the offspring, okay? Somatic mosaicism, mutation arises from a mitotic error after fertilization and propagate through multiple tissues and organs. Again, so the somatic mutation is going to be occurring after fertilization. And what do you think? Is it better to get a mutation before fertilization or after fertilization? Well, I cannot say better, but I can say which one is more lethal. Which one is more lethal? Like the baby is not going to, no baby. Before, absolutely. Before is more lethal. Okay, good. So they write here gonadal mosaicism mutation only in the egg or the sperm. If parent and relative do not have the disease, suspect gonadal one, like a germline mosaicism. For example, the father is okay, the brother is okay, only the patient is having it. So how this happened? Basically, his father had it only in his spermatozoa, or his mother only in her oocyte, but they did not actually have symptoms of it. Okay, so the patient I showed you with Down syndrome right now, he had a normal child, as you saw. So is he somatic or gonadal mosaicism? Absolutely correct. He is a somatic type of mosaicism because, well, if he gets more children, he only got... Yes, that's correct. So the people with the mosaicism are going to be sick, but the children, all of them are going to be healthy. So if he is going to have children, he comes to you and asks you, well, doctor, what is the chance that my children going to have Down syndrome? You will tell him is the exact same chance in the general population, okay? So it basically means like any other human being. So what is the risk factor of Down syndrome, by the way, guys? What is the most common risk factor of Down syndrome, especially in the Western country and the European countries? Absolutely correct. The age above 35 in a lady, and why I said European and US, because look, in the US, for example, yeah, that's true. But in the US, for example, what happens? A lady finishes high school at 18. She goes, let's say, a doctor, for example. She's going to go become a doctor, 4 years of like college, and 4 years of medical school, 3 years of residency, 3 years of fellowship, 1 year of subspecialty, 3 years looking for the significant other, 3 years living with the significant others, and 2 years until they decide to have a child. So it's already late. It's already plus 35. In this category of the patient, you will not tell them not to get pregnant. Of course not. They can. But you will request from them to have more screening during pregnancy. Okay? than the normal population. So, McCune-Alport syndrome is due to a GS protein activating mutation. Remember, the G proteins are proteins that are responsible for a secondary activation inside of the cell. They present with a unilateral cafe au lait spots. Unilateral, is that crossing the midline? Nope. With erect ridges, also they can have something called polystotic fibrous dysplasia, in which the bone is going to become brown from the inside because it's going to be replaced by fibroblast and collagen. And at least one endocrinopathy, oh yeah, they love this one. They are going to have something known as a precocious puberty. When does a female normally have her first menstruation? When does the lady have her first? Yeah, well, it can be anything after age 12. Anything after age 12 is fine. When do we consider it to be precocious puberty? When do you think? Okay, so this is important. You need to write the number down. It's 8 years old. It's 8 years old or before. Because having an 8 years old or before, that's a precocious puberty. I have a crazy question. Can a newborn have a menstrual cycle? I mean like a newborn who was just born, a lady. Yes, she will. Why? How come a baby that does not have functional ovary? Absolutely correct. She was exposed to the hormones of mommy, estrogen and progesterone of mommy, and suddenly she was born. So she's not exposed to estrogen and progesterone of mommy. That can lead to having a menstrual cycle in the baby. Why I'm telling you about this? Because sometimes this can happen, like in the first day after delivery, and you should not be scared. Okay? Just like normal. What to do about it? Nothing. Nothing to do about it. Okay, so now we established the precocious puberty. Lethal if a mutation occurs before fertilization, affecting all cells, but survival in patient with mosaicism. Okay. So if it occurs before fertilization, as we said, the patient is dead. But some of them, if the patient has mosaicism, which means different cells have different origins, they might survive. Also, before fertilization has much more better prognostic value than post-fertilization mutation. Much more poor before fertilization, of course. Loss of heterogeneity and allelic heterogeneity. So what is this? So it's, for example, if you have a mutation at different places lead to similar phenotype. So this was a pleiotropy and variable expressivity. Now we are going to change the stuff. Let's say that, actually let's just do it here. In locus heterogeneity, if you have multiple genes that are located at different places, let's say this is located at the chromosome 7, this is located at the chromosome 11, this is located at the chromosome 15. Of course, this is all from my brain. I don't know which chromosome is have what. I don't know all of the genes. But do we, as a human beings, know all of the genes in our body? Do we know every single gene that exists, big and small, inside of our body? Yes, we do. The genome. Yes, the Genome Project. Okay, so this is different genotype, and they are all going to encode for the exact same phenotype. This is true in case of albinism, retinitis pigmentosa, and familial hypercholesterolemia. So different mutation at different location can lead to it. And allelic heterogeneity, it's different mutation in the same locus. Well, how can I have different mutation? You can have a missense mutation, you can have a nonsense mutation, you can have a frame shift mutation at the exact same site. Doesn't matter which mutation, you are going to have the exact same disease, which is, for example, beta thalassemia. What doesn't matter, missense, nonsense, frame shift, you are still going to have the exact same disease. Heteroplasmy, I love it. And if you don't know it, you are going to lose a point because they always ask about heteroplasmy. So what is the idea of heteroplasmy? It's all about mitochondria. Remember, guys, we get our mitochondria from mommy, not from dad. Our father don't give us mitochondria. He cannot. Because the spermatozoa has the mitochondria inside of its neck, and when it penetrates the oocyte, it loses it outside, so it never goes inside of the oocyte. So all of the mitochondria coming from mommy. So all of the mitochondrial disease obviously will come from mommy. And for does mommy give the mitochondria for the boys or the girls? What do you think? For whom does mommy give mitochondria? Everybody. She's like Santa. Give everybody mitochondria. But it's diseased. For sure, you need it as well. So if the mommy has a diseased mitochondria, this is problematic because she's going to give it to every single child. Okay, but now the question will be like, oh, the first child has really horrible symptoms and like he's almost dead. The second child has much better symptoms, like he has the disease, but he has mild symptoms. You're like, yeah, that's variable expressivity, right? That's wrong. So why it's wrong? Because variable expressivity is for all of the diseases that are not a mitochondrially inherited disease. If you see variable expressivity in a mitochondrially inherited disease, you say it's heteroplasmy. Let me repeat this point. Variable expressivity means like the disease is going to have different severity in different people who inherit the same mutation. And in case of mitochondrial disease, if you have variable expressivity, you don't call it variable expressivity, instead you call it heteroplasmy. So what is the idea of heteroplasmy? I hope I can find an animation to save myself time for not drawing heteroplasmy, but if I don't, I am going to show it to you. Okay, nice, I like it. I found one. So you can see that's patient A, like the first son. He has, like inside of our one cell, we have thousands of mitochondria, of course, not only one mitochondria. You have many mitochondria. So if one is diseased, you are going to have mild disease. If three are diseased, you are going to have a little bit of worse disease. Four are diseased, you are going to have more disease. If like all of them are diseased, you are going to have more severe disease. So that's heteroplasmy. How many mitochondria inside of the cell are affected? So presence of both and normal and mutated mitochondrial DNA, resulting in a variable expression in the mitochondrially inherited disease. Mitochondrial DNA is passed from mother to all of her children. Okay, so the next disease is going to speak about here, but let's speak about it really quick. Uniparental disomy, it's like one parent is responsible for everything. It's like single parent type of thing. Offspring receives both copies of a chromosome from one parent only. What about the other father? He's negligible. He's bad. He gives no copies. He gives nothing to the child. Okay. So that uniparental disomy means one father gives us both copies of the chromosome. What about the other parents? He's an ass. You will never see him. Heterodisomy it like goes something like this. Heterozygote patient and homozygote patient. What is heterozygosity and what is homozygosity? Heterozygosity means that you only have one allele affected. Homozygosity means that you have two alleles affected. Heterozygosity says you have one allele affected. The problem is going to be the meiosis 1 error. I'm not going to in details what is meiosis and mitosis. This will be for reproductive system. While the homozygosity is for homo, it's two allele affected, thus it's a meiosis 2 error. Or a both zygotic chromosomal duplication of one pair of a chromosome and loss of the other one of the original pair. So one parent is going to lose all of his chromosome and he will be useless, and the other other parent is going to have a duplicate of the chromosome which he can give for the offspring. Uniparental is euploid. Euploid, which means that he has a correct number of chromosome, which is like 23, like giving it to the child. Most occurrence of uniparental disomy will have normal phenotype. There is a few diseases, however. Consider isodisomy, which is the homozygote one, in an individual manifesting recessive disease when only one parent is a carrier. You are like, what? Wait, what? So let's say that the patient has an AA, which is the carrier type of a chromosome. It's an autosomal recessive disease, so he should be a carrier, he should not have the disease. However, they give you that the patient has actually symptom. It's autosomal recessive, he should not have the symptom. So if he does truly have the symptoms, probably the healthy gene was mutated and was silenced. So only the pathological one is alive and it's giving symptoms. Examples of uniparental disomy is Prader-Willi and Angelman syndrome, which we are going to speak about here. So the next thing we are going to speak about is the Hardy-Weinberg population genetics. I will try to solve one question with you guys on this, and after that I will send you a video that you must watch and solve the question that comes after it. So when we take a look at anytime you see Hardy-Weinberg population genetics, you have to write two formulas. This is one of the multiple formulas you have to write for in the beginning of your exam. The moment you get the paper, they will give you like a sheet of paper. So you will take that sheet of paper and you will write this on it. So this is the first formula and this is the second formula, P plus Q equal 1. So what is this? If P and Q represents the frequency of alleles of capital A and small a respectively. So what does the big A mean? It means basically the healthy allele. What does the small a represent? It means the sick allele. So the big A means basically the healthy people, the chance of healthy people, right? So right here, frequency of homozygosity of the allele. What is the chance? I'm going to have big A, big A. If I have two letters are the same, I say it's homozygote. If the two letters are different, I say it's heterozygote. It's heterozygote. Heterozygote, two different letters, like big and small. Okay, what about small a, small a? Is it homo or hetero? Homo or hetero? Small a, small a. What do you think? It's homo. It's homo because both of them look the same. Absolutely. So let's see what they write next. The next thing they write here, that B plus Q is equal 1. This formula is a must to know. You will see why in a second. Frequency of homozygosity of allele big A is B to the power 2. And for homozygosity for the sick allele is Q to the power 2. The frequency of heterozygosity, which is the carrier frequency in autosomal recessive, is going to be 2BQ. In the USMLE, what they normally do, that they give you one of these. They just give you one of all of these. I am going to screw up the numbers. I know that from now. So whatever numbers we get, just forgive me for it. I'm just going to give like any numbers just to be able to solve something. So let's say that they tell you that Q to the power 2 is equal to 10,000. So 10,000 is Q to the power 2, which is the amount of sick people in the population, right? And they ask you, in this population, what is the amount, what is the frequency of carriers? So carriers is this thing, right? They are asking us about this thing, the frequency of the carriers, and they give us the Q to the power 2. How much was the Q to the power 2? I told it to you, which was how many sick people do we have? 100,000. Okay, so I should get B and I should get a Q for the sake of solving the carrier, which is 2BQ. I can't get a Q from here. It's easy. I just do like this and I just do like this. Sorry. I just do like this and I just do like this. So Q is equal to how much? 100. Done. Okay, so now I have a Q. Can I get B? Absolutely. So B plus 100 is equal to 1. How much is B? Come on. Yeah, minus 99. But since there is not an actual minus, like you cannot say something is minus, you are just going to make it as 99, right? You cannot have minus 99 carrier. It does not fit. So you are just going to say 99. Again, guys, the numbers are from my brain, so highly likely they are just messed up. I'm just telling. So yeah, it's going to be 99. So now we solve the carrier one. So it's going to be 2 multiplied by the 99 multiplied by 100, which is, somebody solve it, thank you. It's 9,801 is the risk of the carrier of this disease. I'm going to send you a video after the class explaining it further. In the end of the video, I believe that there is a couple of equations that you have to solve them as well. So I see. Well, too late, but you got the point. It's after that it becomes math. You just have to get the Q out of it. How much is the Q? And you plug in the Q here. You get the B. You plug the B here. And you get the B basically from this formula. And yeah, that's pretty much it. There is not much to do. 2 multiplied by B multiplied by Q. And you get yourself some number. Okay? Okay. So let's see. The frequency of an X-linked recessive disease in males is equal to Q, and in females is equal to Q to the power 2. So the formula becomes a little bit different. So what do I mean? Like if we are speaking about a female, what is the risk of a frequency in a female? Yes, you still use the Q to the power 2. But if you speak about males, you remove this. Okay? So in the USMLE, they never ask about the X-linked recessive. They always ask about the autosomal recessive. Hardy-Weinberg law assumption include no mutation occurring in the locus. Natural selection is not occurring. Completely random mating, no net migration, and large population should be checked. Yeah. So basically, if they ask you, is Hardy-Weinberg good for the individuals? Like, can you do it on one person only, your patient? No, this is just ridiculous. It does not fit. It's not for one person. It checks large population. If a population is in Hardy-Weinberg equilibrium, then the values of P and Q remains constant from generation to generation. So if we say we have this perfect population that has the exact same B to the power 2, the exact same Q to the power 2, and the exact same 2BQ, that means that they always have nothing changed in generation to generation, and their B and their Q is going to be exactly the same, but that also means that the disease is not increasing, is not decreasing. So disorder of imprinting. Imprinting means muting, okay? Imprinting, it's like not printing. So it's one gene copy is silenced by methylation. And remember, I told you that we silence with methylation, mute with methylation. And only the other copy is expressed. So it present, parent of origin. Okay, so one copy will be expressed and the other copy is going to be silenced. So two diseases we speak about here are Prader-Willi syndrome and Angelman syndrome. They really want one thing from you in these questions. They want you to know who is silenced. Because if one parent is silenced, the other parents will have the disomy, right? So if one parent is silenced, the other one is going to have the disomy. So you must know who is silenced. Prader-Willi syndrome, it has a P in the beginning, that will be important. Which gene is silenced? Maternally derived genes are silenced. So mommy is silenced, right? So disease occurs when the parental alleles is deleted or mutated. You are like, wait, what? I don't get it. So basically, if we say that, let me see if this is good enough. Yes, it's good enough. Let's say that in mom, the gene is gone. You are like, fine, father will take care of it, right? So the father will take care of it. You are like, wait a second. Now, in the father is also it's gone. You are like, okay, now we have a problem, right? So when it is in one parent's gone and in the other parents you have disomy, you will not actually have a big problem. But if it is gone in both parents, you will have the actual disease. Prader-Willi syndrome has these things. First, hyperphagia, so they eat a lot because of increase of which hormone will be increased in Prader-Willi? I told you about it. Which hormone? Ghrelin. Excellent. I did not expect you to know that actually. Nice. Okay, so ghrelin is going to be increased. And they can have obesity, intellectual disability, small testicles, and hypotonia. The chromosome involved in both of these diseases is chromosome 15, but in Prader-Willi it starts with a B, so it's the paternal origin, which means father. They say here 25% of the cases have a maternal uniparental disomy, which means the mommy has both of the genes. So what does the father have? Nothing. Ah, damn it. So if the mother is going to be silenced, will the child have any gene? The mother have both genes initially, right? She has disomy. So if she's silenced, the child is not going to have anything, right? Because the father is already silenced. So Prader-Willi is going to have obesity, and it has a paternal allele deleted. Paternal allele deleted. Angelman syndrome, paternally derived UBE3 is silenced, and disease occurs when the maternally allele is deleted or mutant. Why? Because the mama here is the disomy. So, but not all the time, 5% of the time, it's not going to be the case. So, the signs and the symptoms, it's like the seizure, the ataxia, intellectual disability, but they don't really care about that. They care about the inappropriate laughter. I advise you to take a look about how this inappropriate laughter looks like, but I hate to do it, but it's like something like this. Okay, it's really weird laugh, and yeah, the first time I heard that I got scared. So these patients are mostly going to be females, and they are going to have this inappropriate laugh. The phenotype is going to be like really huge, which means that you might have seen it in your class or in somewhere. You have seen it somewhere, I assure you. If you forgot, I can enhance your memory by telling you about that stupid girl that used to sit in your class, and when something funny happens, she makes something like this. Sorry, karma. So yeah, they have, I'm not saying stupid because they are stupid. No, they do have actual intellectual disability. It's not by their hand. Okay, so yeah, sometimes they can have that ataxia. And the next thing they write here, yeah, the maternal copy of the chromosome 15 will be the one messed up, so Angelman has an M. So 5% only is due to uniparental disomy. Okay. So maternal allele will be deleted. Angelman syndrome, mood, ataxia, and seizures can occur in the patient. Okay, good. So let's have a little break, guys. And after the break, in 11 minutes, we'll come back and we'll hit these two patients. So see you guys in 11 minutes. About this. Okay, so let's take a look. The next thing we are going to speak about is the autosomal dominant recessive X-linked dominant X-linked recessive and mitochondrial disease. So, starting with the autosomal dominant disease. Autosomal dominant disease goes something like this. Just like a quick overview, what is the chance of transmitting an autosomal dominant to your son? How much do you think it is? Okay, what about autosomal recessive? Okay, that's good. What about, yeah, okay, who has more risk of getting an X-linked disease, men or ladies? Men, absolutely, right. Okay, good. So they write here, autosomal dominant. If you take a look at a pedigree of autosomal dominant disease, just a common trick. Look, is there any generation spared or all generation are affected in some way? All generation are affected. Generation 1 is affected, generation 2 is affected, generation 3 is affected. So if the disease affects all generation, start thinking that it is dominant. I'm not saying autosomal, but I'm telling you for sure it's dominant. Okay, after that, first check, what is the next thing to check for? In this case, is it affecting men or women? In this pedigree, is it men or women? It's both. So since it's both, it's autosomal dominant. But if it was only men, it will be X-linked dominant. Okay, so let's take a look here. Often due to a defect in a structural gene, many generation, both males and females can be affected. So if you have only one of the affected alleles, you will have the diseased one. So guys, please do not be tricked. They must tell you which allele is the sick one. So in this case, for example, they are considering the big A to be the sick allele. It could be the small a the sick allele. It all depends on the question. If they don't tell you, you can tell yourself, well, okay, the big allele is the sick one and the small allele is always the healthy one, or vice versa. So both males and females can be affected. So often pleiotropic, which means has multiple apparently unrelated effect and can have this variable expressivity, which is different severity between different individuals. And family history is crucial for the diagnosis. Why? Because absolutely the parents will be affected. If we have an autosomal dominant disease, remember please about the idea of penetrance. Like in case of Marfan syndrome, we spoke about incomplete penetrance, and that was the reason why it's not in all generation, right? Family history, basically the patient, if you check the genotype, she has it, but the phenotype does not exist. Family history is crucial for the diagnosis. With one affected heterozygous parent, heterozygous means like, okay, they write one heterozygous parent. I'm going to write three things in front of you, and you will tell me what is the genotype of the parents. Is it this? 1? Or is it 2? Or is it 3? 2. Absolutely, it's 2 because heterozygote. Each one has different, like one affected, one non-affected. On average, 50% of the offspring are going to be affected. Autosomal recessive, okay, let's take a look again. Is it affecting all generation or is it skipping generation? No, it's not, it's skipping. Skipping means that it is not dominant, so recessive. Okay, is it affecting, is it affecting only boys? Or is there any lady getting affected? Yeah, there is a lady getting affected there, so it cannot be X-linked. So with two carriers, heterozygote parent, on average, 1/4 of the children will be affected. Half of the children will be carriers, and 1/4 of the children will be neither affected nor carriers. To understand this, I have to draw a little bit. So they said, like, if both parents are carriers, well, they have this heterozygosity. Why they are not sick? Because it's an autosomal recessive disease. So let's try to see the offspring, how they are going to be. So first of all, it can be like this. Big A, big A, big A, small a, big A, small a, small a, small a. So the big A, big A, it means healthy. Big A, small a is carrier, the carrier, sick. So 25% chance of being sick, 50% chance of being carrier, and 25% chance of being healthy in the offspring. Okay, and that's what they write. They write also here, often due to an enzymatic defect, usually seen only in one generation, and commonly more severe than a dominant disorder. Patient often present in childhood. This is good. Remember, please, all of the dominant diseases have late presentation. And if you remember, Botter sequence, does it happen in the autosomal recessive or autosomal dominant polycystic kidney disease? The Botter sequence. Only in the recessive one. Why? Because the dominant one will have later presentation, while the recessive one has early presentation. Okay, so they write, often due to enzymatic deficiency, usually seen in only one generation, commonly more severe than dominant disorder. Patient often present in childhood. Increased risk of consanguineous family. What is this? Sanguineous in Latin means blood. So it's in families that have a lot of mixing of blood, like how do you call it? Cousins marrying each other, for example. Okay, so it's not actually healthy to get married from somebody from your same family. And in case if you did something like that, you need a little bit of more to do a little bit more testing before you go forward and do that, just to make sure that your offspring are going to be healthy. Unaffected individual with affected sibling has 2/3 the probability of being carrier. So yeah, if his brother has it and he does not have it, so the right unaffected individual with affected sibling must be carrier. What does that even mean? Well, is the patient having any symptom? The answer is not. So can he be small a if he has zero symptoms? They are telling us he's unaffected. So it cannot be small a. Okay, so what it can be if he does not have symptoms? He can either be a carrier or he can be actually healthy. So what is the chance of him being healthy? It's 1/3. What is the chance of him being carrier? It's 2/3. Okay. So they write here, see 2/3 probability of being a carrier. X-linked recessive, okay, skipping generation affecting males only. So sons of heterozygote mother have 50% chance of being affected. No male-to-male transmission. Why? Because our father only gave us the Y chromosome, and this disease is X-linked. So our father never gave us an X chromosome. No male-to-male transmission, and it skips generation. So commonly more severe in males. Females must be homozygote to be affected, which is much more difficult to occur. Not impossible, but much more difficult. X-linked dominant. X-linked dominant. Is it skipping generation? No, it's not skipping generation. It's affecting every single generation, actually. Okay, good. And the next question comes, well, is it affecting men or ladies? Now, this one is tricky because actually it can affect both, okay? But there is something to notice here. It's X-linked disease. So can the father transmit it to his sons? Okay, and as you can see here, the affected father here does not transmit it for his sons. So it's transmitted through both parents. Mother transmit to 50% of daughters and sons, but father transmit to all daughters but no sons. Why the father transmit for all daughters? Because father have XY chromosome. Which of these two is the father giving for his daughters? Only X. The father cannot give them Y. Okay, which one is given to the boys? Y. So Y is always healthy. Yep. So they write here, so the father will not transmit to the sons, but he will transmit for all of his daughters. So what I do actually when I get such a question is that I look at the father and I look at the offspring. So I see that all of the daughters are affected, but none of the boys is affected. So I'm getting suspicious. It's involving every generation, and most likely it will be like only one disease actually that, few diseases that actually you have to know about. One of them is super important actually. So we have a Fragile X syndrome. These patients will have hypogonadism, intellectual disability. We'll speak about it later. But the important one actually is Alport syndrome. Where did we spoke about Alport syndrome before? Yes. So in this disease, what do we have exactly? We have failure of formation of type 4 collagen, which is going to lead to defect in the basement membrane in both of the lungs and the kidney, right? And they write here, Also, hypophosphatemic rickets can be an X-linked dominant disease. A hypophosphatemia can occur, and phosphate wasting at the proximal tubule can occur, which lead to a rickets-like presentation. Because to mineralize the bone, we need calcium, we need vitamin D, and we need phosphorus. If you trash all of the phosphorus, this is problematic. Why? Because we cannot mineralize our bone. The last thing here they mention is the mitochondrial inheritance. Mitochondrial inheritance, it's transmitted only through the mother. All offspring of the affected females may show signs of the disease. Okay, so mommy give the disease for whom? All of them. Notice, mommy give it to all, but father give it to nobody. Mommy give it to all again. So it's variable expression in the population or even within the family due to heteroplasmy. So because we don't like to use variable expression, we use instead heteroplasmy, which basically represent how many of the mitochondria are affected inside of one cell, right? The more affected, the more heteroplasmy, the more symptoms we are going to occur. We have the following: mitochondrial myopathies. So myopathies, rare disorder, always on the exam. I'm telling you guys, you know this touche marker, the yellow one, just make the whole thing yellow because they will ask about every single point. Often presents with something known as MELAS. MELAS. So MELAS is this thing, this syndrome. M for mitochondrial, also the myopathy. E for encephalopathy, which is the CNS disease. L for lactic acidosis. And yeah, so I have a question. It might be typical for you. You'll be like, oh yeah, just a list, I have to memorize it. Not really. Look, mitochondria is responsible for internal respiration, right? So if the mitochondria is not working, can you do internal respiration? I mean electron transport chain and oxidative phosphorylation? You cannot, because the mitochondria is defective. So what is the other pathway to make energy? Anaerobic glycolysis, absolutely. Anaerobic glycolysis will create lactic acidosis, which give you like muscle weakness and myopathy. Also, your brain needs a lot of ATP. Do you think anaerobic glycolysis is sufficient enough to provide the brain with enough ATP? The answer is not. Anaerobic glycolysis as a sum give you only 2 ATPs, while mitochondria give you 32. So you can see that the brain is going to be suffering. That's why we get the encephalopathy. Okay, MELAS syndromes, we get mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes due to a failure of the oxidative phosphorylation inside of the mitochondria, which is the process that makes us the ATP. Muscle biopsy will often show something known as the ragged red fibers due to accumulation of diseased mitochondria in the subsarcolemma of the muscle fibers. Let me show you actually how the red ragged fibers look like. Yes, this one. Take a look. Notice that it is like near the cytoplasm of the muscle cell. Okay. Good. So the next thing we have liver hereditary optic neuropathy. I hate this disease. We'll have cell death in the optic neurons, subacute bilateral vision loss in teens or young adults, and mostly in males. However, the most important thing to know, it's permanent. There is nothing to do. Also leads to a neurological dysfunction, cardiac conduction defect. They don't ask about this. They mostly ask about MELAS. They mostly ask about MELAS on the exam. But if I was you, I would like to know that this one is permanent. I mean the liver optic neuropathy. Here they have a table in which you have all of the autosomal dominant and autosomal recessive one. They are so many, there is no way to memorize them in such way. I highly advise you to do the songs I sent you, which is the autosomal dominant one. In the same link, if you go to the right, you will find the autosomal recessive one and the X-linked one. Try to do all of these so you can get all of these questions correct. Okay, so I think that's it for today. Tomorrow we are going to speak about cystic fibrosis and we'll keep pushing. We'll finish genetics actually tomorrow. It's not that much we have left. I told you it's super, super short. So we'll finish genetics tomorrow and even we will have some times to start something new. So I'm going to open one more bowl to ask you what would you like to do next. Would you like to do nutrition or would you like to continue with MSK? It's all up to you. So see you guys tomorrow.